as far as any kind of questions that you have, that you can just put those into the chat, and then I'll have you speak to Jocelyn. But this is also being recorded for my podcast. So we're going to go ahead and kick that off. I'm going to mute everybody to start. We're good. And all right, so welcome back to Mastering Menopause. Today, I'm so excited to be joined by Dr. Jocelyn Wallace, who is an expert on pelvic health. And she reached out and said, hey, I think I would be a great guest for your podcast. So absolutely. And in the meantime, we had some scheduling and you had a hysterectomy. So I would love to talk about your experience with that. How did you prepare for that? How are you optimizing your recovery? I've seen all the exercises that you're doing, but before we do all that, would you mind just telling us what it is that you do and what is your expertise?
Absolutely. Thank you so much for having me. My name is Jocelyn. I've been dealing with fibroids personally for over 10 years, and I've had 4 surgeries, culminating in a hysterectomy that I had almost 6 weeks ago. So I've been having repetitive surgeries to deal with this, and along the way became a physical therapist, and from firsthand experience got to see the limited support and the really conflicting advice that people can get after having surgeries and procedures like this. So I made it my mission to correct that for people and support them in getting back into exercise and fitness, because it's important to take care of our whole bodies after surgeries like this. I opened my business in 2018. So for the past 6 years, I've been slowly niching down to working only with hysterectomies, myomectomies, prolapse repairs, all the pelvic surgeries that don't have so much to do with perinatal and postpartum issues. So now that's what I work with exclusively. So my typical client is someone in her 35 to 55 who's recently had a hysterectomy or another pelvic related surgery, who is interested in getting back to fitness and lifting heavy and won't take no for an answer.
I love that. So, yeah, I love that you're like showing women how to get back into the exercise, what it is that you can do, rather than like, it's my understanding, and I get this a lot from my clients, that they're like, yeah, my doctor said just not to lift heavy for 6 weeks or something like that, right? So after these surgeries, it's like, so I would love to hear kind of your journey. I think that, and this is just from my observation and conversations that I've had with women, is that when they're preparing for something like this, they're mostly concerned about how much weight can they lose before they go into a surgery like this, because they're not going to be able to do the things that they want to do. And I think that's a huge disservice to your body, to the psyche, and to how you're actually going to be able to go through a procedure like this and then be able to optimize your recovery. So let's start with, how do you prepare your body for something like this, assuming you do have time? I'm not talking about an emergency surgery that you have to have, but
yeah, you put that beautifully. There's so many factors that go into preparing for surgery, and losing as much weight as quickly as possible is the last thing that somebody can do. I always say you should treat having a surgery like this like you're going into an athletic event. Imagine you were going to do a CrossFit competition. You're not going to prepare for that by starving yourself. You're going to go into that recovered, well rested, emotionally cared for. You're going to go into that from a good place. So big picture, approach it in that way. When we get down to the more granular details of preparing for a surgery like a hysterectomy, everyone's worried about their pelvic floor, rightfully so. Having a hysterectomy, especially if the uterus and the cervix is removed, is a permanent change to somebody's anatomy, and the pelvic floor can take some impacts from that. But the best thing you can do to prepare your pelvic floor before a surgery is, number one, address any issues that you already have. So if you're already having leaking, or you're already having urgency or frequency, if you already have a problem, learn about that problem. Do what you can to help improve it before having surgery, even if you're having the surgery to help improve it even further. If you don't have any problems like that, then learning about how to take the best possible care of your pelvic floor can be really valuable before going into a surgery, especially, again, if you're going to have a vaginal cuff, because we don't want repetitive strain down on that fresh incision. So a vaginal cuff is where they close off the top of the vagina after removing the cervix. So we don't want repetitive strain down on that. So learning, what does it mean to strain your pelvic floor? Because it's so much more than just lifting or not lifting, or lifting 45 pounds instead of 55 pounds, because the weight guidelines that people are given can be incredibly arbitrary. So some of the things that I find that a lot of people don't realize that can be bad for your pelvic floor are things like squatting over the toilet seat. As much as you possibly can, you should always sit on the toilet seat, even in public places. If it's a germaphobe issue, you can get these disposable toilet seat covers that you can put in your purse, and they come like little single packets that you can carry around with you. Constipation is a big deal for your pelvic floor. So doing whatever you need to do, make sure you're getting your fiber, take stool softeners, do whatever needs to get done to make sure you're not straining through constipation leading into surgery. And then power peeing. So power peeing is the habit of trying to rush your stream because you need to get back to work, or you have a child to tend to, and you're trying to get in and out of the bathroom as quickly as possible. That forced stream puts strain on your pelvic floor over time. And it doesn't feel like a big deal when you're healthy and everything's good, but when you just had major surgery, it can become a big deal and can result in setbacks. So making sure that you take care of your pelvic floor, and then making sure that you strengthen everything around the pelvic floor. So I'm going to hold up my pelvis for the people that can see. But when you think about your pelvic floor creates the bottom of your pelvis. So it surrounds your vulva, it goes from one side of your sit bone to the other. It's like the base of a bowl. But then our glutes help to stabilize that and take a lot of the force of running and lifting and things, making sure that you're strengthening all of the muscles that support the pelvis and not just the pelvic floor itself, especially if you have a certain weakness or something that you know that you struggle with or that you're bad at. Some of the things that I see often are the hips. So people that will struggle with like inner thigh strength or struggle with their single leg balance, like maybe they're doing Bulgarian split squats and they're the person that always falls over and feels like they can't balance. That would be an example of something that would be really valuable to work on leading into surgery. So the physical preparation, you want to think about what are your weaknesses and address them as much as you can, depending on the timeline that you have. And then nutrition, treating it like you're going into an athletic event. So you want to make sure you're getting enough protein. The recommendation surrounding surgery is 1.5 grams per kilogram of body weight. So not per pound of body weight, the bare minimum amount of protein that you want to eat around any surgery, but especially a surgery with multiple incisions in vulnerable places.
Yeah, I'm always about nutrition and in the protein. It's like so important, you know, for just for optimal health, right? But in general health, I didn't realize, like thinking about that, you know, with in regards to surgery as well, going into it. So, what, as far as, like, I'm sure you're going to go into specific exercises, but what are some things, like, what are the hard things that you would absolutely avoid besides the things
after surgery?
Talking about? Yeah.
Yeah. After surgery, so you want to avoid bearing down on your pelvic floor. So for most people, that's going to happen with impact exercise. Most people are not ready to do jumping jacks, for example, in the first 4 to 6, maybe even 8 weeks after surgery. And anything where you're holding your breath or needing a hard Valsalva, like you would do when you're heavy lifting. And that's not to mean that you should never do that again, but most people are not ready for it at 6 weeks, and definitely not before 6 weeks, which can be a big part of the problem of the typical recommendations. It's do nothing and then just do whatever with no guidance beyond that. And most people are ready for something before 6 weeks, but they're not ready for everything, or for testing the 1 rep max or doing a full out CrossFit WOD at 6 weeks. There needs to be much more support in getting people through that bridge back to fitness. And it also depends so much on what's leading to surgery and what they've been through heading into surgery. Because like I had a hysterectomy for really large, numerous fibroids, and I've had 3 of my surgeries in 3 years since 2021. So my situation is more complicated than somebody else's. I'm going to have a longer path before I can just do whatever I want in the gym, versus somebody else, maybe it's their first surgery, they've never had any kind of other trauma, they've never had any kind of other issues. They're going to have a simpler path compared to somebody that maybe is having surgery for the cancer, for example. They're having a hysterectomy for that reason. which is terrible to go through, but they don't have an enlarged uterus in most cases, not to the extent that like large fibroids will create. So they're going to have a different set of issues to work through, and their physical recovery might be better because they haven't been basically pregnant for years, which is a lot like what having fibroids can feel like.
Oh, wow. Okay. Yeah, that's very interesting. I loved, so I've been, ever since I've been following you, I'm seeing your stories, right? I'm saying, hey, check out her stories, because you're showing your progressions, and this is like in real life, like what are you doing and how are you preparing for that, you know, and taking the steps. And so I have dropped your Instagram link, and we had like 35 women signed up for this masterclass. So they're all getting the replay. So maybe I'm starting to get the messages like, hey, can't make it. I'm going to catch you on the replay. So
yeah, you know how it goes.
But I was like guiding them to say, like, check out Jocelyn's stories, because she's going over this in real time, and what are the steps that you can take that you're talking about, where we don't get the support that we need from our doctors. And it's just, it sucks. It's just terrible. Like, here, just don't lift for 4 to 6 weeks, right? And you're saying, absolutely, you should be doing something, you know, just not to that capacity. So, so how did you physically prepare yourself for, like, what are the things that you focused on before you went into this last surgery?
Yeah, so the big picture, I did a general progressive strength training program for about 3 months leading into surgery. So doing squats, deadlifts, overhead presses, and then I did some core strengthening, like sit-ups, planks, deep core exercise for the transverse abdominis. So that's things like dead bugs is a common one, exercises like that. My big thing working into surgery was my adductor strength. So after having 3 surgeries and having a mass in the pelvis, like when your pelvis has been under pressure, one of the big things that can start to weaken over time are the inner thigh muscles. So I love an exercise called Copenhagen plank. So it's meant for people listening, like imagine you're in a side plank position. Yeah. And you have one leg on top of the weight bench, and you're using the leg on top of the weight bench to hold your body up. It's like the most advanced version of the exercise, but that groin strength can go quickly when you have pelvic issues, and that can start to contribute to pelvic floor weakness and stuff. So that was my big focus, was rebuilding my strength in my adductors. And I had to start with basic, you know, modifications. And right before surgery, I finally got back to being able to do a full, like, standard Copenhagen plank. And then the symptoms tough. That yeah, there's so many different ways to work on a similar concept without needing to do like that specific one. But I like lifting. I squat hundreds of pounds and stuff. So to be able to do that, you want to have really good balance strength in the supporting muscles. And then my fibroids personally tend to cause more pelvic floor tension symptoms. So I was experiencing urinary retention, which is when you can't fully empty your bladder, or like you go and then you get up and it's like, oh, I just peed, but I need to sit down and go again. I had a lot of that. So I did a lot of like pelvic opening types of things, like child's pose, happy baby, deep breathing exercises, and making sure that I wasn't trying to force that last bit of urine out, even though it can be really tempting to do so, because like, especially when you're going to the bathroom every hour, every 45 minutes, just want to get it over with. It can be so frustrating. So making sure that I didn't do that power PA, that I did a lot of pelvic floor relaxation exercises, especially after working out, as like a sort of cool down. And then another thing that can really help that I use all the time is humming while you urinate, or singing while you urinate. It helps to relax your pelvic floor and can help to get those last bits out without having to push and like try to strain to fully empty your bladder.
Yeah, I've never really heard the term power peeing. So I think I'm guilty of it though.
Yeah. A lot of us build that habit, especially with, you know, you're trying to get back to work and you're trying to get in and out of the bathroom real quick. I mean, it's not harmful to do it sometimes, but when you're doing it over a lifetime, it can start to make you more vulnerable. And it can also keep you from fully emptying the bladder. When if you leave a little bit of urine, like sitting in the bladder or the urethra, it can be irritating. It can contribute to GSM symptoms, which is the genital urinary syndrome of menopause. It can worsen that kind of stuff. And sometimes people don't even realize that that's happening. And it can be an easy fix to get some relief.
Yeah, that's very interesting. Yeah, as a bartender for 30 years, I definitely spent the bulk of that
Yeah.
time get back to work.
Yeah, nurses, teachers, they can
Yeah.
be some people that have the hardest time with this stuff.
Well, but from what I understand, it's because they wait too long to empty their bladder, right? We're going through
Yeah.
long shifts with
Yeah.
teaching and nursing. So that was there was an interesting I follow, do you know Dalla Devitt? Have you heard of Dalla Devitt? She does Dalla
No.
does bells. So she had that experience as a nurse, and that affected her pregnancy for sure.
Mhm.
So 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 that's how you prepared for the surgery, and then you obviously have the surgery, and now can you just kind of walk us through like your progression that you've had since? Like what are the next
Yeah.
like the next steps?
Yeah. So I went home the same day. I had a robotic laparoscopic hysterectomy, a total hysterectomy, which means they removed the uterus and the cervix, and the fallopian tubes, but I kept my ovaries, and all those little details really matter a lot. So the kind of surgery that I have means that I have 4 incisions, 1 in my belly button and then 3 along my abdomen. And then they removed my cervix, so they close off the top of the vagina, and that's what's called a vaginal cuff. There are 4 belly incisions and then the internal incision. So you get to go home the same day in the US for those kinds of surgeries most often. So I went home the same day, and I started moving. I certainly wouldn't call it working out, but I started moving the very next day. So the first stage is pain reduction, getting the gas out. So I did a lot of like standing child's pose, standing cat cows. So imagine using your arms to support your body weight on a countertop. You can kind of get back into that position and do those same kind of movements without needing to get down on the floor when you're not ready yet. But a lot of that kind of stuff. For laparoscopic surgeries, they pump you full of gas so that they can expand your stomach so that there's space for them to work around because they don't have a big incision like a C-section. So you're full of this air, and it's not the same as digestive gas. It's like your body's a balloon. And that's where a lot of the pain comes from. So doing movements to help get rid of that. And then my first workout, quote unquote workout, was about 3 days after surgery. That is documented on my Instagram. And I did some all unweighted. I did some RDLs. That's when I was able to get down on the ground and do some other mobility movements. And I did some deep core exercise lying on my back. So lying on your back is the lowest pressure way of working your core when you're just lying and not doing like a sit up or anything like that. Because it takes off the postural demands of being upright or seated in a chair. So lying on my back and doing lots of deep breathing. When you have surgeries like this, it can cause a lot of restriction in the abdomen and the pelvis. So one of the next first phases is making sure that you can get a full inhale, which can be really hard for people sometimes to even fill up their body with air and then in turn be able to exhale. So one of the first rehab priorities with everyone that I work with is getting their inhale fully restored so that they can then exhale. Because when we exhale, especially when you exhale fully, the cue I use often is to think about trying to get every last bit of air out of your lungs or try to blow up a balloon. Like imagine you had a weighted resistance kind of balloon and you were trying to really fill it with air. That kind of exhale helps to turn on your pelvic floor and your deep core muscles and get them firing again. And we need those muscles to fire reflexively, to laugh, sneeze, cough, do all that stuff without pain. So working on that as soon as possible helps to get that reflex back on. And then it doesn't hurt as much to sit up out of a chair or when you cough or sneeze and stuff. So that was the first phase of what I started working on.
Can I just ask you?
I started doing. Oh yeah, go ahead.
You said that you have trouble inhaling. Is that because you're inflamed or because of the gas? Like, can you expand on that a little bit, or just
absolutely.
Shallow breathers? Like, I don't know.
Yeah, both. You're inflamed and full of gas, so it's like you're trying to take an inhale into your lungs, and it's just like imagine the worst bloating you've ever had, where it feels like your chest won't move and your body doesn't want to open up or relax. It feels a lot like that. And then you can also get post-operative pneumonia, and the lungs can kind of slow down after any kind of surgery and being under anesthesia. That's why a lot of hospitals give you that little breathing device that you inhale into. So if your lungs have been affected by the anesthesia, and I don't mean that in a permanent injury way, but if everything's just kind of slower, getting that working again will help you feel better, faster, clear any congestion left in the lungs. And hospitals used to, and this is just in like the 10-year span that I've been in the medical field, hospitals used to give everyone an incentive spirometer and tell them to start that deep breathing every hour. And they don't do that nearly as often anymore, especially now that they keep making more and more surgeries like hysterectomies outpatient. So people aren't getting this tool, and it can really work wonders for helping people feel better faster.
Okay, thank you very much for that clarification. I found that interesting.
Yeah, of course. So then I around a week, I also started upper body exercise. So just the basics, bicep curls, shoulder presses, stuff like that. Not working to muscle failure or anywhere where I would even try to touch Valsalva. Like, it's just about keeping the joints moving, keeping the muscles used to the load. Because another problem, like do nothing for 6 weeks and then do whatever, is now you just had 6 weeks of not using your shoulder that maybe you had a rotator cuff issue in the past. And like you're just letting the rest of your body get deconditioned when there's so much gray area between do nothing and do everything. So I started with basic upper body exercises, and then worked into the hinging. I've been going a little slower on squatting, which I can elaborate on why, and then progressing my core exercises, starting with things where I'm lying flat on my back for a few weeks, and then working into hands and knees or quadruped, which just works your abs a little harder. And then around 3.5 to 4 weeks, when I first started doing more dynamic core exercise. So like starting to test whether I can do a sit up well and doing planks and stuff like that.
Yeah, I would definitely love to hear that progression, because I think we put so much pressure, right, on ourselves to just be able to recover as fast as possible so that we can get back to doing the things that we want to do. And I need to recover as fast as possible. And it was like not honoring your body and where you're at. So I love hearing about these progressions.
Yeah. So an example of that would be like me with squatting. So after having all these, my last 2 surgeries were both open abdominal incisions. So my core took a big hit. And then having this one, like my squat has never quite gotten back to where it was before all of these past 3 years. So when I do squat, I have a hard time managing pressure. So I feel like I really want to hold my breath. I can't get myself to breathe with them. And I feel some downward pressure into the pelvis. So those are my yellow flags, and yellow flags is a language that I give warning signs that mean you shouldn't do an exercise at the level that you're doing it, even if you're cleared. There's still yellow flags that you want to look out for, even if your doctor told you you're ready to exercise. So with me, it happens in squats. I feel downward pelvic pressure. So I just squatted a barbell a few days ago, which is like a teeny percentage of what I would normally use weight-wise. Because again, weight restrictions are meaningless. Like if you normally squat 100 pounds, 10 pounds is no big deal to you. Versus if someone can barely squat to get on and off the toilet, 10 pounds is a big deal for them. And the weight restrictions are just kind of thrown out with no consideration for who the human being is. So when I say I squatted a barbell already, I'm saying that in the context of that's very little weight for me. Not that everybody needs to be squatting a barbell at almost 6 weeks post-op. But getting back to squatting, I'm going to have to be much more careful than I am with other movements because I'm feeling that downward pressure. So the way that I'm managing that is doing more tempo squats so I can like pay attention to what my body's feeling, keeping the weight light, and focusing on exhaling on the way up. So when we breathe out, it helps to take pressure out of the pelvic cavity and out of the abdominal cavity, and helps to reduce that sensation. But that doesn't mean I can't ever hold my breath to squat again. That's just what I'm doing right now so that I can still squat and still maintain that movement pattern and keep my muscles used to it while I'm waiting for my body to be ready for heavier squatting.
Yeah. Do you mind sharing, like, and maybe you don't know the exact numbers, but how much did so before when you like optimal, not, I shouldn't say optimal, but your heaviest squat, like how much did that decline? Like what were you at, like where were you at, and like where are you now before your, this last surgery?
Yeah, my heaviest squat ever was 325. But that was in 2019. I was doing competitive strongman in 2019. So I was like training to be really, really strong.
Yeah.
And then 2020-ish started my like more heavily into CrossFit era. So around then I was squatting like 245, typically in a CrossFit class. And then right before my surgery, I was at 175, right before this surgery. So I would say realistically, like the change was about in the mid 200s to the around the high 100s.
Yeah. So significant. Although I would say you
significant.
also push your boundaries too. Not everybody's squatting in the 200s.
Yeah.
If you're at 300.
Yeah.
So.
And through this journey too, my goals have changed so much because through these last 3 years, I've become a mother. I've had all these surgeries. So my goals have changed a lot. I don't have any aspirations to squat 300 pounds again at this point in my life. I'm learning this person I can be these days.
Yeah. It's the transition, right, from the stages where you have the time and you can have the energy and the ability and the stamina to do something, pursue those goals, changes with motherhood, changes with menopause. There's like just these, we're not always going to be able to do the things that, that we used to do, or and our goals change. And that's fine.
Yeah. I want to be able to hold my daughter for a long time without my back getting tired and run at a moment's notice to chase after her. Like those are my goals now.
Yeah, absolutely. So what else, like, so you're at 6 weeks now, right? And I'm seeing your progressions, like you're like, you can get to running, right? But I saw you doing like speed lunges, things like, or what's that called? Side to side lunges.
Skaters usually.
Skaters,
that's what people call them. So I'm not a big runner. Like becoming a better runner is one of my goals. So I'm working on return to run plyometrics now. I'm also not a very bouncy person. I don't have good force absorption. I'm not very athletic in that way. And that is, again, one of my goals now, and something that I see gets neglected a lot in women that are typically having these surgeries. Even if they tend to lift, they still often can't remember the last time they jumped on one leg or did a box jump or did anything that made them feel like springy and powerful. So I think that training that stuff is really important for long-term pelvic floor health. And those muscle fibers that make us fast, that make us quick, those are the same muscle fibers that we lose first as we get older, as we go through menopause. They're also muscle fibers that are responsible for, like, when you're running, in order to not pee, your pelvic floor has to be able to repetitively contract quickly to be able to keep up with your running so that you don't leak. So I think it's really important for just about everybody to be doing some kind of speed training in their regular workouts. Maybe they're not ready for that at 6 weeks, but at some point in the time past their surgery, I think it's important to get back to.
Yeah, that's interesting too. And just overall, right, as we age, we lose that ability and we stop doing those things because we can't do those anymore. And it's like really important that you continue to have that ability. Yeah, you're not going to be able to do the same thing that you did when you were 30 or 40, but you should be able to stand on one leg. You should be able to jump up and down. You should be able to jump up on something and jump down. And I see, because I used to do group classes where women were just afraid to even jump up on a box like that, so it's important. You had a post about frailty, right? You want to avoid that and make sure that you go, like, you take care of your body so that you age well. So I think that's, I love your message.
Absolutely. No, thank you.
Let's see. So I'm not sure if Patricia has any questions. Amy's question pretty much mimicked everything that was in the group too, when I asked about, does anybody have any questions around this? And this was very common. Like, I had hysterectomy years ago. What is it that I can do to strengthen my core? And then Amy's Adam specifically is asking for suggestions on how to strengthen core and stamina if your hysterectomy was years ago. So that was a pretty common theme.
Yeah. So when surgery was years ago, the first step is figuring out what do you mean by stamina? where does your core start to break down or become weak? So is it that something I see a lot, people can't do a sit-up. So if that's the case, there you go. You have a goal to work on, is being able to do a sit-up. Or is it that maybe every time you do a plank, your back hurts and you don't feel like you can target your abs? Maybe you need to modify your plank, put your knees on the ground, or go over plank form again and work on quality over quantity, and make sure that you're building upon whatever weaknesses that you have. That's big picture. Like, there's nothing wrong with all of the basic fitness exercises. The thing that goes wrong is that people are trying to do what they see other people doing instead of doing it at the right level for them and the right quality so that they can actually get better at it. So another example of that was something like sit-ups. Is I often see people, like, depending on their arms, to throw their body and use momentum. So, like, sure, you're sitting up and you're doing a sit-up, but you're not making your abs any stronger doing them that way. You're not going to get anywhere. You're not going to get any further with that. So first, just looking at what are the core exercises you're already doing and how can you make those better so that they're actually getting you the result that you're trying to get.
Yeah, we're always seeing this fancy shiny object over here. Oh, look at this! This looks cool, right? Instead of focusing on the basics, we're just checking boxes a lot of times instead of really focusing on, like, hey, how can we make this better? There's always improvements made to the basics, I feel. So
absolutely.
Can you also speak on incontinence? Because I think that's one that a lot of my ladies struggle with, and I guess we have to address like why, right?
Yeah, definitely. The first thing to look at, especially if you are in perimenopausal or menopausal range, is the hormone profile, and making sure that you're getting HRT if you need it, you're getting vaginal estrogen if you need it. There is such thing as incontinence that has nothing to do with your pelvic floor muscle function, that you need hormonal support to help it get all the way better. So that's step number one. I see a lot of people like spinning their wheels with pelvic PT, with Kegels, with Kegel training devices and stuff, and that's not what they need. They need the hormonal support to deal with it. The next thing is to find out, where is your incontinence coming from, and like, how severe is it? Like, document what's actually happening. Is it happening every time you laugh, cough, sneeze, or is it only happening after you've run 2 miles and your pelvic floor really fatigues? And then knowing that the pelvic floor is just muscles, just like anything else, and we train them like any other muscle in the body. So let's say you can do your workouts fine and you don't have any leaking unless you do jumping jacks. And now it's jumping jacks where you're leaking. The right approach to that is not to stop doing jumping jacks. It's to, one, look at the quality of your jumping jacks. The most common form issue that I see with jumping jacks and just impact exercises like that is not having the core engaged and depending on spine extension. So you'll see that called rib flare a lot. So like, they'll be sticking their bellies out, sticking their butt back, puffing their chest up, and the back looks really arched. Your body can't manage pressure effectively in that alignment. So the cues that I use often for things like that is, think about pulling your pubic bone to your rib cage, downward gaze, so you look slightly down in front of you. So it helps to keep your rib cage down because your back will follow your head. And then think about zipping up. So like pulling your abdomen, like pulling the pubic bone up towards your ribs to get that support from your core, and then doing the jumping jacks. Sometimes it's as simple as making those alterations to your form and the leaking gets better. Sometimes it's more of an endurance issue. So maybe you can do 30 seconds of jumping jacks, but on the next set, you start leaking as things get tired. The approach there is to, if your threshold is 30 seconds, now maybe you do intervals of 20 seconds with a 1-minute rest. So you can progressively build your endurance for the problematic activity, versus the way that this is often treated is to just pull back from the activity that's causing leaking for months and months and months while someone does Kegels, and they feel fine. But then when they go and try to do jumping jacks again, now they're leaking again because they never address the actual endurance for the activity. When someone has incontinence that's more on the severe side, like they're leaking with day-to-day activities, every time they cough, every time they sneeze, they can't control it. Those are usually the cases where people often do benefit from some pelvic floor muscle training. That's like Kegels, and like specifically isolating those muscles. but then the bridge has to be built to those functional activities. So some things that we use often is like practicing fast contractions of the pelvic floor. So if you think of like a metronome, your pelvic floor should be able to contract, relax, contract, relax, contract, relax, like a metronome does. So sometimes people can have a really good long contraction, and they can hold a Kegel for a long time. Or if they feel a sneeze coming, for example, they can brace for that sneeze and keep themselves from leaking. But when they have a sneezing fit and they're sneezing one after the other, the pelvic floor can't keep up the coordination. So you have to walk through those steps. So first build the strength, then build the coordination, then practice the activities that were causing leaking in the past, and do it at the right dose for the individual.
Awesome. Thank you very much for answering that. All right, so Patty has a pretty specific case, right? She's scheduled for a hysterectomy in July 1st, coming up very soon, and she's recovering from a partial quad tear. So she's currently not very fit. I guess we're going to ask you some more questions on that, Patty. And she's asking, she said she would love some suggestions for knee-friendly exercises that would help recovery. So do we need to know the basis of her?
Yeah, we would need to know like how severe the quad tear is, what kinds of positions you are like able to tolerate. Like, can you not squat at all, or can you squat lightly or in certain positions? Or can you not lunge? Just any exercise that uses the legs. We would have to know how able you are to do those things, how severe the quad tear was, and that kind of thing to be able to say what exercises you can start with. But even if someone is bedbound, there's something that they can do.
Yeah, so I guess we need to know what currently not fit means. Patricia, can you unmute yourself, or can you give us some insight? So she might not be in a position where she can talk.
Yeah,
is what I'm assuming. So, as I think, can we address like knee-friendly exercises that would help recovery?
Yeah. So when I hear knee friendly, I think mostly like things that don't use deep knee flexion. So for most knee pain, most knee injuries, it's going to be things that create deep knee flexion. So that means where your knee is bending a lot. So that could mean like doing a box squat instead of a regular squat where you're going all the way down. That can mean emphasizing hinging exercises like RDLs over a full conventional deadlift all the way to the floor. That could mean single leg hinging where you're not standing on both knees, which is often more uncomfortable for people. So that could mean like a single leg RDL to make sure that you're building that balance, that pelvic strength and stability, but you're not repetitively bending the knee, which is the thing that most commonly bothers people's knees. And then most core exercises can be done lying down on your back and shouldn't involve the knee much at all, except for things that involve like being on your knees. But on your back, anything like the dead bugs that I mentioned earlier, and various deep core exercises that aren't unanimously named in the fitness space. Like there's no clear name that you can just go Google to find them. But the muscles that we want to target are the pelvic floor and the transverse abdominis. And then the way that you know you're targeting that with the core exercise that you're doing is when you breathe out forcefully through your mouth. So if you blow out as if you're blowing out a birthday candle, like you should feel your stomach go in and up. So I often have people look at their belly button and see when you blow like that, does your stomach and your belly button go in and up? If when you blow like that and you try to contract your core, your rib cage crunches down and your stomach pushes out, then you're not using those muscles that are like first order of business after any kind of surgery that cuts into the abdomen. We want those muscles back to life. So if instead you're pushing your stomach out, or if when you try core exercises, your stomach is like pushing out, and you have like a roll right underneath your rib cage, that can be a sign that you have this issue. And any core exercise that you are able to do and able to tolerate, you can practice not doing that in that core exercise. So that could be a blank, that could be anything that you could name. It could even be just standing up and looking in the mirror and practicing contracting your core without tucking your rib cage down and making the line underneath the rib cage and not pooping your abdomen out. I see it all the time where people's whole coordination is reversed after going through things that have harmed their abdomen, including pregnancies, including major weight gain, that where they've like grown quickly over a period of time, like hernias. And when they inhale, they suck in. It's also some social conditioning and training to always walk around sucked in. So we develop this pattern of breathing in and holding our bellies in and picking our bodies up and arching our back and trying to get as small as possible, when it should really be reversed. When you inhale, your stomach should expand so that then your abs can actually contract. Because the way a lot of us are walking around, it's as if you walk around with your elbow bent all the time. Over time, you would lose the ability to straighten your elbow. If you don't straighten your elbow, you can't contract your bicep, and your bicep is going to weaken over time.
Yeah, it's kind of like where people wear like waist trainers or something for their posture, right? That's kind of holding them, and then they're taking out the muscle element at all, and it actually leads to them being weak. So, oh, we got Patricia on. So she said she's having difficulty with bending, and that she's been working on hinging. So I think we did address that as far as, deep bending. Yeah. So I think Jocelyn addressed that. So
I also just got my microphone to work.
Okay. Thank you. Now, what about like basic guidelines? I feel like this would all apply. I have a client who just had her gallbladder out, like an emergency gallbladder surgery. So what are the just the basic guidelines for after surgery?
Yeah, so nutritionally, 1.5 grams of protein per kilogram of body weight, that is absolutely essential. Exercise-wise, there are no protocols for any of these surgeries versus like almost every other surgery you can name. There's surgical protocols for these things, and abdominal surgeries just don't get the same attention, especially the ones that women have. So there's no clear consensus. What we do know in the research is that people that are given more liberal recommendations and encouraged to exercise sooner do better. They have a lower risk of incisional hernias after every kind of abdominal surgery. They have lower reported prolapse symptoms after pelvic surgeries, lower reported incidences of incontinence. So getting moving in a gentle way that's safe for you as soon as possible is essential and does absolutely make a difference. In my clinical experience, the thing that makes the most difference for helping people feel better the fastest is getting those muscles turned back on, the transverse abdominis, which most people have the most success like having that happen by using the breathing. Like it sounds so simple and so just want me to breathe every day for a few minutes and focus on certain things, but it really does get people feeling better faster. I've seen people that had pain with coughing for months and months after abdominal surgeries. They didn't have to go through that if someone would have just taught them how to reestablish this coordination. And it really, really, really makes a difference and can be started immediately. I'm a huge advocate for anyone that's in the hospital after any kind of abdominal surgery. Ask them for an incentive spirometer, unless they're going to charge you like $1,000 for it, but they should usually give it to you. And then it's a device that you breathe into it, and you're trying to inhale as much as possible, which means you're getting as much expansion of your abdomen and your pelvic floor as possible, so that then you can breathe that air out and get the fullest contraction as possible, which is going to turn that reflex back on and make you feel more normal more quickly. Anybody that has any kind of surgery that cuts into the abdomen should have their scar assessed eventually. So that can be done with a physical therapist. There are some massage therapists that have training in scar work. You can ask your surgeon or your physician to take a closer look at it, because they often just kind of poke you in the stomach and say you're good to go. But we want to make sure that the scar isn't painful after. It depends on the surgery, but eventually the scar should not hurt to the touch. The skin around the scar and the muscles under the scar should not hurt to the touch. So we want to make sure that that goes away, that the scar moves quickly and moves easily. So if you think about like the skin on your chest, how it moves around pretty easily for most people, you want the skin on your stomach to move around a lot like that. And if the scar is bound down and like has developed scar tissue where it's holding it down to the fat or tissue underneath it, that can create movement restrictions and discomfort and stuff over time. We want to make sure that the scar is moving well, that it's not painful. And then the most important thing that anybody can do after these surgeries is if you already strength train, you need to keep strength training. If you don't strength train already, you need to get with a professional and learn how to strength train. That is the most powerful thing you can do to take care of everything below the belly button for the rest of your life, is to keep everything around it strong, and including your pelvic floor. They've done some studies that have shown that a lot of exercises like hip thrusts was one, has more pelvic floor activation than a Kegel or any pelvic floor strengthening exercises. So keeping those muscles strong also keeps your pelvic floor strong, because it's also muscles, which means that when we experience sarcopenia or muscle loss, so is our pelvic floor, so is all the stuff that we're worrying about. It's going to make us more vulnerable to prolapse and incontinence and all the things that people worry about.
Yeah, thank you very much for that. It's really just is like the basics, you know, and expanding on those. So I love your message about strength training and, you know, getting in the protein and looking at your nutrition and, you know, just really going that way for any kind of procedure, you know, including, you know, what you've just recently undergone. So I highly encourage anybody that's listening to follow Dr. Jocelyn on Instagram. I will drop her link to that. If you're not already following her, check out her stories and look at her recovery process. And then do you have like a program? I have the link for that, but can you talk about that a little bit?
Yeah, so the program that I offer is called 90-Day Revival. So it's a 3-month process. So I work with people that just had surgery, as well as people that maybe had surgery months or years ago, but still have problems they haven't been able to figure out how to overcome. So it's a 3-month process that involves a combination of face-to-face time and then digital programming, so exercises. And I often teach people bladder retraining techniques, arm massage techniques, whatever they need to get over the symptoms that they're dealing with. Then I also have in the links on my Instagram a pelvic floor questionnaire that people can download that asks you questions about just what you're experiencing. And it can be great for understanding like what's normal and what's not, and getting the language to be able to actually communicate about this stuff, because so many of us are living with things that we don't even realize aren't normal and don't know how to communicate it with our doctors. And our doctors also don't ask. It's just like, you have these surgeries, and then it's like, if you have any problems, and you're like, well, I'm not in excruciating pain, but I can't have an orgasm anymore. But people don't bring that up often unless asked. So it's a questionnaire that can kind of clue you into maybe there is a problem, that, and then you have the language to be able to communicate about it.
Awesome. Yeah, I'll drop those links too for everyone that is listening. And is there anything else that you would like to add?
No, I think we covered it all. Thank you so much for having me.
Okay. Yeah, no, thank you very much. I appreciate your time. This has been very helpful and insightful. And I know everybody's going to get some value out of this, whether they are undergoing, like Patricia is, you know, having a surgery, or has just recently had one, or even years past. You know, what can we do to help our health and help the pelvic floor going forward? So thank you very much. I appreciate your time. And I'll see you on Instagram.
Thank you. Yeah, see you. Have a good day.
You too. Bye.